Akshata, please. Dr. Akshata, please.
Good evening, everybody. So I'll be presenting a case of bilateral immune keratitis, prevention before perforation. Peripheral corneal ulceration or peripheral ulcerative keratitis is usually a crescent-shaped destructive inflammation of juxtalimbal corneal stroma. It presents with epithelial defect, presence of stromal infiltratory cells, progressive stromal degradation and thinning. Collagen vascular diseases are responsible for approximately half of non-infectious causes of PUK. A clinical presentation, a 52-year-old female was referred to us from respiratory medicine as the patient complained of diminution of vision in both eyes, watering, foreign body sensation and intolerance to light for 2 weeks. Known case of diabetes and hypertension since 20 years. Known case of rheumatoid arthritis, discontinued medications 15 years ago. Admitted currently for breathlessness, under evaluation for obstructive airway disorder. On examination, visual acuity in the right eye was counting finger 1 meter and the left eye was counting finger 3 meters. Lids and conjunctiva was normal. Cornea, bilaterally, we could see in the first picture I can see stromal thinning noted inferior temporal quadrant in both the eyes. Peripheral corneal infiltrates were noted 2 mm from the limbus circumferentially and subepithelial punctate erosions were also noted on day 1. So on day 6, the peripheral corneal infiltrates we could see resolving, they were resolving, and also stromal thinning was still noted in the inferior temporal quadrant. On day 16th, again we could see FS staining positive and they were resolving SPKs and resolving peripheral infiltrates were seen. As we can see that the cornea is clear now. On day 26, the resolving peripheral infiltrates were seen and there was also corneal reepithelialization was seen in the area where the corneal thinning was noted. Coming to fundus examination, media is hazy in both eyes, cup-disc ratio was normal, peripapillary area was normal in both eyes, blood vessels were attenuated, macula FR was dull. Dry eye evaluation, Shermer's test, in the right eye it was 4 mm and in the left eye it was 5 mm. T-bud test was less than 3 seconds in both the eyes. Clinical presentation, there was a swan neck deformity seen and ulnar deviation of metacarpophalangeal joint and rheumatoid nodules were noted. Investigations, CBC was normal, whereas ESR was raised 88 mm per hour and RBS was 280 mg per dl. Rest RA factor, ANA profile, sputum sample was negative for Mycobacterium tuberculosis and MON2 was negative. Management, the patient was managed with Gatiflox plus prednisolone eye drops for 2 weeks, 6 times. Sodium hyaluronate eye drops were used. Cyclosporin eye drops was given BD. Lacrygal eye ointment was used. Home atropine 0.03% eye drops was used. Tablet doxycycline was used and tapered. It was first BD and then OD. The immunologist started on tablet methotrexate 10 mg once a week and hydrochloroquinone 250 mg BD. Conclusion, PUK is a vision-threatening condition that requires prompt treatment to stabilize the cornea. Don't wait until tomorrow to intervene. A multidisciplinary approach to investigations and management is required with collaboration with various specialists. Patient rightly diagnosed and timely treated can show response to treatment. Thank you.
Good presentation, Dr. Akshata. And one query is that with this presentation of severe dry eye, can anything else be done to prevent this PUK from happening by the ophthalmologist per se? In terms of multi-specialty approach, that is okay. The case was referred from TBRD itself.
Yes.
But primary prevention of PUK in severe dry eye.
Excessive lubrication can be given to the patient.
Okay. And we can see from pictures there is a significant grade 3 nuclear sclerosis cataract.
Yes, NST.
So the patient would need cataract surgery. Any precautions that you would then take when you take up the patient for surgery? A case of known dry eye with PUK healed.
Cyclosporins would be started with excessive lubrication first to stabilize the patient, and later once the patient condition stables and corneal reepithelialization is noted, we can take her up for surgery, sir.